Hi students, today we will learn about functions of the cerebellum and cerebellar lesions. Coming to the functions of the vestibulocerebellum. Its function is to control body posture and equilibrium. The afferents will come from vestibulocerebellar tract, which carries static and kinetic equilibrium, and spinocerebellar tract, and from cuneocerebellar tract, and from reticular formation, that is reticulocerebellar tracts. The efferents will go to vestibular nuclei, reticular nuclei of the brainstem via the inferior peduncle. The vestibulocerebellum works through fastigial nucleus. It influences spinal motor neurons and position of the eye in relation to head via the medial longitudinal vesicles. So, these are the functions of vestibulocerebellum to control body posture and equilibrium. So, it takes the afferents from all these tracts: vestibulo, spino, cuneo, and reticulocerebellar tracts. And efferents will go to vestibular and reticular nuclei via the inferior peduncle, and this is working with the help of fastigial nucleus. It is one of the deep cerebellar nucleus, and it influences the spinal motor neurons and position of the eye in relation to head via medial longitudinal fasciculus. Then coming to functions of the spinocerebellum. It is for controlling of the muscle tone and stretch reflexes. The afferents will come from spino, cuneo, olivo, and tectocerebellar tracts. The efferents will go to bulbar, reticular, olivary, and vestibulonuclei via its tracts. It will work through emboliformis nucleus and globosus nucleus. Both are together called nucleus interpositus. They rely on the alpha and gamma motor neurons, and they will facilitate gamma motor neurons. Okay, via cerebello-vestibulospinal tract and cerebello-reticulospinal tracts mainly. So, they will facilitate gamma motor neurons. Here you can see this is the muscle spindle. In later on videos, there will be detailed discussion on the muscle spindle. So, you can see nuclear chain fibers, and these are nuclear chain fibers, and these are nuclear bag fibers, and these are the extrafusal muscle fibers. These are the intrafusal muscle fibers. The intrafusal muscle fibers is again divided into nuclear bag fibers and nuclear chain fibers. So, the afferents will go from the nuclear bag fibers through group 1A fiber. Okay, it is carrying afferent information from the middle part of the nuclear bag fiber and nuclear chain fibers. Okay. This 1A neuron. Okay, this one. Okay, this one. This is. It is going through dorsal root ganglion, and it is entering into the spinal cord gray matter. Okay. Then from the nuclear chain fiber, group 2 fiber will carry the afferent information. Then they will influence the alpha motor neuron. This dotted one is the gamma motor neuron. This continuous one is the alpha motor neuron. So, alpha motor neuron will supply the efferent connection to the extrafusal muscle fibers. This gamma motor neuron is the efferent connection to the intrafusal muscle fibers. Okay. So, whenever it is stretched, that is whenever the intrafusal muscle fibers get stretched, then group 1A fiber will be fired. Then it will activate alpha motor neuron, and it will start contraction of the extrafusal muscle fibers, so that whole muscle will contract and intrafusal muscle fibers will also be contracting. So they will be contracting. So contraction of the whole muscle. Okay. So these are influenced by our cerebellum. Coming to the function of the cerebrocerebellum or corticocerebellum. It is to control the voluntary movements. It is via open feedback loop and closed feedback loop. So coming to open feedback loop, what is an open feedback system? It has an input. The input will be processed and output will be given. Here, the input is coming from cerebral cortex through corticopontine fibers to the pontine nuclei. Then this pontine nuclei will send its information to the cerebellum via pontocerebellar fibers. Then these are processed in the cerebellum, and via the dentate nucleus, the dentorubral fibers will be arising to the red nucleus. Then this red nucleus will send its fibers to the thalamus via rubrothalamic tract. Then this thalamus will send its fibers information to the cerebral cortex via thalamocortical fibers. Okay. So it is cerebropontocerebellar tract. Then this is the input. It will be processed in the cerebellum. Then this is dentato or dentorubro-thalamic cortical tract. This is the output. This is an example of open feedback system. So we have already seen these two tracts here. This is the input, cerebropontocerebellar tract. This is the output, dentato-rubro-thalamic cortical tract. The function is to modulate the motor command of the pyramidal tract. So it can modulate the motor command which is given by the pyramidal tract. Here in this closed feedback loop, the input is coming from cerebral cortex, okay, via corticopontine fibers to the pontine nucleus. Then through middle cerebellar peduncle, the information will come to dentate nucleus. Okay. Then, and it also receives information from the inferior olivary nucleus through inferior cerebellar peduncle. Then this dentate nucleus processes the information and gives it outputs through superior cerebellar peduncle to the red nucleus or to the thalamus. Then this will influence the corticospinal tract. So these are the descending fibers, that is corticopontine fibers. These are the some descending fibers of the corticospinal tract. So here it is giving information to cerebellum via this pathway. Then again it is getting information through the cerebellum, okay, which is getting its information through the inferior olivary nucleus also, what is happening in the body. Then it will match the information and it will give its output through the dentate nucleus, and it will influence the corticospinal output. And from the pontine nucleus, and from the red nucleus, this information will also go to the reticular formation, that is via rubroreticular tract, and to the thalamus, that is through the rubrothalamic tract, and also to the spinal cord via rubrospinal tract. This is the closed feedback loop. So here the input, which is the corticospinal tract, that is the input is coming from the corticospinal tract. The motor output, it can be modulated by the influence of the cerebellum here, so that output can also be modulated. So here you can see the afferents and efferents. Afferents are the collaterals from the corticospinal tract. It will go to ipsilateral pontine nuclei, olivary nuclei, and reticular nuclei of the medulla. And the efferents will go to dentatothalamic and dentatorubral. It controls voluntary movements and coordinates the movements initiated by cerebral cortex. Coming to its mechanism of action, it is having 5 mechanisms of actions. That is, first one is comparator function, second one is damping action, third one is timing and programming the movements, fourth one is controlling of the ballistic movements, and fifth one is servo mechanism. See here the mode of action of cerebellum in controlling voluntary movements. Cerebellar comparator function. So this is the cerebellar comparator function. So what is happening here? Where is the cerebellum? Here you have cerebellum. This is the thalamus. This is the motor cortex, and this is the spinal cord. Okay. These are the skeletal muscles, which are the effectors. The motor cortex, okay, sends action potentials to the lower motor neurons in the spinal cord. So motor cortex is sending its impulses to the spinal cord. Then what will happen? The action potentials from the motor cortex inform the cerebellum of the intended movement. So this motor cortex is planned some movement that is communicated to the spinal cord. Then what is happening in the middle? This information will also go to the cerebellum. Then what is happening? The lower motor neurons, that is alpha motor neurons in the spinal cord, send its action potentials to the skeletal muscles, causing them to contract. Next, what will happen in the fourth one? The proprioceptive signals from the skeletal muscles and joints, okay, these impulses will go to the cerebellum and convey information to the cerebellum about the status of the muscles and the structures being moved during contraction. So in the contraction, the skeletal muscles and joints will also be moved, no? So about that information, that proprioceptive information will go to the cerebellum. Next, the cerebellum compares the information from the motor cortex, okay, and the proprioceptive information which is coming from the skeletal muscles and joints. So it compares the 2 and 4. This number 2 and number 4 information. It is comparing here. Then the action potentials from the cerebellum, okay, the action potentials from the cerebellum to the spinal cord modify the stimulation from the motor cortex to the lower motor neurons through the red nucleus. Okay. So it is comparing. If there is any difference, it will modify the information. Okay. Modify the information about the stimulation to the spinal cord via red nucleus. So it will send information to the red nucleus. Then this red nucleus will send its information through the cerebrospinal tract to the spinal cord. Then this lower motor neuron will be affected. That is, its action will be changed. The action potentials from the cerebellum are sent to the motor cortex via thalamus, and it will modify its motor activity also. Okay. So this is the pathway. So the cerebellum, it acts as a comparator. So what it comparison makes? So from the motor cortex, information is coming to the spinal cord, but its a copy is going to the cerebellum also. Here the lower motor neuron gets activated and skeletal muscles and joints are contracted. Then this proprioceptive information is going to the cerebellum. This information and the information which is coming from the motor cortex, they are compared, and if there is any difference, it will be intimated to the spinal cord via red nucleus, and it will also be intimated to the motor cortex via the thalamus. So it is a cerebellar comparator function. It will control the voluntary movements. Next, coming to damping function. So, the cerebellum prevents the exaggerated muscular activity, okay, and makes voluntary activities in a smooth and accurate manner. And the voluntary movements are initiated in motor areas of the cerebral cortex, you know. The corticocerebellum receives information from the motor cortex as well as feedback signals from the muscles as soon as the muscular activity starts. Okay, and sends information back to the motor cortex to cut off the extra impulses. So we have seen the comparator function. So with the help of that, it will cut off the extra impulses. So that is it will cut off the exaggerated muscular activity. It is called damping function. Then it plays a role in timing and programming of the voluntary movement. It determines the future position of the moving limb and controls the rate, range, force and direction of the movement during rapid, progressive and sequential motor movement such as writing, walking, running and talking. So it can anticipate the future position of the moving limb, okay, and it can control the rate, range, force and direction of the movement during a rapid movements. Next, it is mediated with the help of two-way neuronal connections between the cerebellum and premotor and sensory cortex. How it is performing this action? That is because of the two-way connections between the cerebral cortex and the cerebellum. Then coming to next function, that is cerebellar control of ballistic movements. Okay, so ballistic movements are most rapid movements. So it will control these ballistic type of movements. So for example, movements of fingers in typing. Okay, here what is happening? There is no time to send feedback impulses to the cerebellum or from cerebellum back to motor cortex. So because the actions or movements are occurring rapidly, so there is no time for the cerebral cortex also to send the information to the cerebellum, or there is no time to the cerebellum to send its impulses back to the motor cortex. Okay. Here the ballistic movements, the entire movement is pre-planned and set to go a specific distance and stop. So these ballistic movements are controlled by cerebellum. Next, coming to fifth one, servo mechanism. It is the correction of any disturbance or interference in performing skilled work. Okay, once skilled works are learned, the sequential movements are performed without interruption. Okay, so it is also done by corticocerebellum. However, if any disturbance is there in the corticocerebellum, immediately it can influence this work mechanism, that is servo mechanism. So for example, if a particular work is learned, the sequence of the movements are there in the cerebellum and they are performed without any interruption. So it will decrease the burden on the cerebral cortex. Then coming to cerebellar lesions. There will be disturbances in tone and posture. Okay. There will be disturbances in the tone and posture. This leads to atonia or hypotonia, deviation movements, attitudinal changes, and deep tendon reflexes become weak and pendular. And disturbances in equilibrium will lead to wide-based gait. Disturbances in movement will lead to ataxia or a decomposition of movements, asynergia, dysmetria, and intention tremors, nystagmus, dysarthria, astasia or abasia. So you can see here disturbances in tone and posture. Okay, tone and posture. It leads to atonia or hypotonia. There is reduction in the muscle tone. Okay? And attitudinal changes. Attitudinal changes means lowering of the shoulder on the affected side, rotation of the face towards the opposite side as it is pulled by the healthy muscles. Okay, and trunk is bent, concavity towards the affected side. So attitude is changed because of the atonia or hypotonia. Deviation movements can be occurred and attitude is also changed. And the deep tendon reflexes TTR becomes weak and pendular. For example, pendular knee jerk. Okay, due to hypotonia of the quadriceps muscles. Then coming to disturbances in equilibrium. It leads to wide based gait. So the person will walk on a wide base and sways from side to side. That is also called drunken gait. And he is unable to maintain the upright posture. Okay. Then coming to disturbances in movement. Ataxia. That is lack of coordination of movements. It is the hallmark of the cerebellar lesions. So here you can see decomposition of the movements. That is, movements seem to occur in stages at different joints. So at each joint the movement will be occurring and you are able to see that movement. Then asynergia, that is lack of coordination between the agonist and antagonist muscles. Then dysmetria, that is the movements are incorrect in range, direction and force. So the movements can be overshooted. Okay, that is hypermetria, or the movements can be fall short of the distance, that is hypometria. So dysmetria, it can be hypometria or hypermetria. The person cannot reach that destination. The hand may be overshooting or undershooting. Then intention tremors. So these tremors are not present when the person is at rest. When these will appear? These tremors are appearing when the movements are started, when the movements are at the end of that movement. Means when suppose a person's hand is there, he is trying to catch a cup. Then when the tremor will be appearing at the end of the movement, that is when that hand is approaching the object. And these tremors are coarse, oscillating to and fro and rhythmic. So these tremors are rhythmic movements, coarse movements, oscillating to and fro movements. Okay. Then coming to nystagmus. Nystagmus is a regular and rhythmic to and fro movements of the eyes. Okay. Because of the incoordination of the extraocular muscles. Okay. And this is due to damage of the flocculonodular lobe and occurs at rest also. Okay. So this nystagmus can occur at rest also. That is to and fro involuntary movement of the oscillatory movements of the eyes because of the incoordination between the extraocular muscles. Then coming to dysarthria or a scanning speech. It is because of the incoordination of the various muscles which are involved in the speech. So how the speech will be? The speech will be prolonged, slurred, with pauses at wrong places. Then coming to astasia or abasia. Means unsteady voluntary movements across multiple joints. Okay, the movements are unsteady. Okay, and loss of ability to maintain upright posture against the gravity. So the person is not able to maintain posture against the gravity. That is abasia. Okay, astasia means unsteady voluntary movements. So ataxia, astasia, abasia, okay, dysarthria, nystagmus and intention tremors. So disturbances in the movement can lead to ataxia, abasia, astasia, dysarthria, intention tremors and nystagmus. Disturbances in the equilibrium will lead to wide-based gait. And disturbances in the tone and posture lead to atonia or hypotonia. Tone is decreased. And because of that, attitudinal changes will be occurring. And deviation movements will be occurring. And DTR, that is deep tendon reflexes, how they will be? They will become weak and pendular. So, here you can see the movement is controlled by corticocerebellum or cerebrocerebellum. The equilibrium by vestibulocerebellum and the tone and posture is controlled by spinocerebellum. Here you can see the rebound phenomenon means when the patient is attempted to do a movement against resistance. So for example, if his hand is there, okay, and this hand is going to touch his nose, but you are offering some resistance to his hand. If you remove the resistance forcibly, okay, he cannot stop his hand. He will hit his face. That is rebound phenomenon. It is because of the inability of the agonist and antagonist muscles to adapt to rapid changes in the load. So it is a defect in the muscles. So they cannot adapt so rapidly to rapid changes in the load. Then gait test. Okay, when the patient is asked to walk on a straight line, he is not able to do. He follows a zigzag path. Then past pointing. That is, the movement will go beyond the intended point. This is also called overshooting or dysmetria. So, if the patient he wants to touch an object, but he cannot touch that object, the hand will go out of that object. So, that is past pointing. Then heel to shin test. So, what is this test? The person should lie supine or standing. Maybe in the supine position is convenient. The patient is asked to place the heel on the opposite knee. Then that heel should slide down from up to down through the shin between the knee joint and ankle joint. So if he is not able to do that test, then the test is abnormal. Then coming to Romberg's sign. Okay. So if the patient is asked to stand erect with closed eyes, he will swing. Then it is called Romberg's sign positive. Okay. But this sign is not specific for cerebellar ataxia because it may be positive for other reasons also. The other reasons also can cause ataxia, and in those also Romberg sign is positive. So this sign is not specific to cerebellar lesion. But if a cerebellar lesion is there, if a person is asked to stand erect with closed eyes, he cannot stand, he will sway. Then it is called Romberg sign positive. So what are the clinical tests for cerebellar dysfunction? Finger nose test, adidochokinesia or dysdiadochokinesia, rebound phenomenon, gait test. Here it can be with open eyes also. The person can open his eyes and ask to walk. Then past pointing, then heel to shin test, then last comes Romberg's sign. You observe this ventral intermediate nucleus of the thalamus. Okay, so it is called VIM, ventral intermediate nucleus. So it is not shown in the regular textbooks of the textbooks which are giving classification of the nuclei of the thalamus. It is present in the inferior edge of the ventrolateral thalamus. Okay, so according to a scientist called Hessler. Okay, Hessler. So according to his classification, it is also belonging to the motor thalamic nuclei. So you already know the motor thalamic nuclei are ventrolateral and ventroanterior nucleus. So where it is present, this VIM nuclei is present in the inferior edge of the ventrolateral thalamus. Okay, and it is a wedge shaped area which is present inferior edge of the ventrolateral thalamus, and it is also concerned with the motor system. Okay, next video is about the physiological anatomy, neuronal circuits and functions of the basal ganglia.